Yeah. Good evening, everyone, and welcome to today's wonderful evening with Dr. Syed. Dr. Syed, always enthusiastic, energetic, and very keen to teach. And we are quite lucky to have him over here today. And, so,
Hello.
uh, yeah. Am I audible?
Yes, sir. Some
Yeah.
disturbance was there, sir, in between.
1 minute. Just a moment. Yes. Now, am I audible?
Yes, sir. Yes, sir.
Great. So let's make the great beginning today with let's learn about how we manage the heart failure. Heart failure is a very common topic where shortness of breath is a common complaint, and every resident, every general practitioner's day in and day out topic. And thank you so much, Dr. Syed, for picking up this wonderful topic, which is a arm army topic every day that we face this topic. So let's make the great beginning.
Thanks a lot, sir. Thanks a lot for giving me this opportunity to present this presentation in front of all wonderful doctors. So today's topic is heart failure management, a clinical scenario-based approach. Heart failure is a very big topic, and it has lots of issues in it. Recognition of heart failure, then investigation to diagnose heart failure, then medical therapy for heart failure, device therapy for heart failure, role of myocardial biopsy in heart failure, and all. And it is very difficult to uh, cover all these issues in heart failure, but I am trying to present and give some insight regarding heart failure management, the cases that I have saw in my clinical practice, and the cases that I have treated, where I think just having a approach of starting just anti-heart failure medication is not enough in treating heart failure, but you have to think more in patient who come to you with heart failure. Let's start this scenario based approach with case number one. So he was a 50-year-old male patient. He was clerk in company by profession, and I received call from hospital at 12 o'clock in the night that this patient has arrived in the ER. He was diabetic, hypertensive, and he is having breathlessness. He is having body swelling, and he is complaining that he has increased his weight since 6 months and is having very decreased functional capacity. So I went to ER. I saw that patient is lying on the bed and he is breathless and he is orthopneic, and he has been inclined 45-degree on the ER bed, and his pulse was 100 beats per minute. Blood pressure was 100 by 70 mm of Hg. Saturation was around 92% on room air, like that, and they have started him on oxygen inhalation. On examination, I could see that he was having pedal edema. In respiratory system examination, they were bilateral basal cryptations. His JVP was raised, and in investigation, we found that ECG showed sinus tachycardia, and there were no significant STT changes in the ECG. So, indicating that acute myocardial ischemia was not there. So, I did the echo bedside, and I found that he had dilated all cardiac chambers with global LV hypokinesia with severe LV systolic dysfunction, and he was having moderate TR and moderate PH. So this patient had developed LV dysfunction, and this LV dysfunction, that is left heart problem, that caused pulmonary arterial hypertension. The commonest cause of right heart failure is left heart issues. So this same has happened in this patient. Patient developed first LV dysfunction, and that translated to the right side, and he developed RV dysfunction as well as moderate TR and moderate PH. So basically, this patient was in congestive cardiac failure with biventricular dysfunction. So we started this patient on IV diuretics, dobutamine, Lasix infusion, and we sent routine investigation like fasting lipid profile, thyroid profile, and HbA1c. So treating any heart failure patient is important to send at least these three: lipid profile, thyroid profile, and HbA1c, because lipid profile will guide you if the patient may be having underlying coronary artery disease that may be responsible for LV dysfunction, that is ischemic cardiomyopathy. Thyroid issues like hyperthyroidism or hypothyroidism can too cause myocardial dysfunction and cause heart failure, while HbA1c points to you towards how much controlled diabetes is, or if patient is uncontrolled diabetes, because diabetic patient, if they have long duration of uncontrolled status, heart also get develops diabetic cardiomyopathy, that can be also a reason of heart failure. Also diabetes can lead to atherosclerosis leading to ischemic cardiomyopathy. So this patient was started on IV diuretics, IV dobutamine, antiplatelet, statin, and we started him on insulin for his diabetes and other supportive medication we gave. Slowly, slowly he started to improve, and we added this patient on angiotensin receptor neprilysin inhibitor, that is ARNI, Vimada, beta blockers, and dapagliflozin. So while in hospital, he lost 8 kg of weight. This 8 kg of weight was nothing but extra water that was collected in his body due to renin, angiotensin, aldosterone system activation and sympathetic nervous system activation, which is a maladaptive mechanism of body while patient body tries to cope up with dysfunctional left ventricle. So we found that pre-discharge we did his echo, and we found that his right ventricular systolic pressure was coming down. Although his LV function didn't improve yet, but his RVSP improved. So it was indicator that he was responding to the treatment, and his subsequent improvement, he very much improved. His functional capacity improved, his weight decreased, and he became mobile. His orthopnea decreased, and he was okay. So after that, OP basis, we did his again 2D echo, and we found that gradually his severe LV dysfunction, which was having ejection fraction 30%, it improved to fair LV systolic function 50%. So I have to give a message that uh, anti-heart failure medication not only they treat heart failure, but they cause reverse remodeling of the patient. The remodeling of the heart, which has been done due to RAS and sympathetic nervous system activation. Once you block RAS and once you block sympathetic nervous system with ARNI and beta blockers, or AC inhibitors and beta blockers, or ARB and beta blocker, and you give diuretic, mineralocorticoid receptor antagonist, and other proven medication, anti-heart failure medication, they not only stop the remodeling, but they cause reverse remodeling. And if you observe the patient gradually, you will see that LV size decreases in this patient and LV function improves. So now as his LV function has improved and he was completely dry, and there was no any extra fluid in his body, which would have been causing him breathlessness. Now we decided to check his coronaries. So we did coronary angiogram to see if there is underlying coronary artery disease, and we found that his coronaries was normal. So he was actually a case of non-ischemic dilated cardiomyopathy. So that was the reason behind his cardiac dysfunction. So many reason of cardiac dysfunction can be there: ischemic cardiomyopathy, non-ischemic cardiomyopathy, nutritional deficiencies, and all. So we found that he is having non-ischemic cardiomyopathy, probably um, secondary to some genetic problem, or secondary to diabetes leading to diabetic cardiomyopathy. And once all these issues were solved, his LV function improved. So take home message case is that any cardiac dysfunction presents to you, you should do lipid profile, thyroid profile, fasting blood sugar, post lunch blood sugar, HbA1c, to rule out underlying issues, as this can be a reason behind development of LV dysfunction. Initially, we should give IV diuretic like loop diuretic, and mineralocorticoid receptor antagonist should be added. And if the patient develops hypokalemia, you should not stop diuretic, but you should treat the potassium level with the help of IV correction and addition of mineralocorticoid receptor antagonists like aldactone and now finrenone, like that. Gradually, angiotensin receptor neprilysin inhibitor, AC, ARBs, beta blockers, gilflosin should be initiated in this patient. Anti-heart failure medication work, and they not only stop remodeling of heart, but they cause reverse remodeling of the heart, leading to decreased LV size and improved ejection fraction. Decrease right ventricular systolic pressure due to improvement in left-sided issues. Treating heart failure is just like treating diabetes. So once as you treat diabetes, once you stop medication of diabetes, again sugar level get uncontrolled and HbA1c increases. Same will happen in heart failure patient also. Once you stop anti heart failure medication, again their heart will dilate and they will develop LV dysfunction. So it is not indicated that once anti heart failure medication work and you achieve a fair LV function, you should stop medication. You should continue the medication to maintain a sustained response and to maintain sustained ejection fraction. And also with this case, I want to tell that this patient is under follow up since 4 or 5 years, and he is doing well and he is on all medication. And severe LV dysfunction is not a death sentence. And we should not think that, oh, severe LV dysfunction, what will happen to this patient? No, there is always hope for the patient. You should treat the heart failure, and there are many chances that their LV function will improve, their symptoms will improve. We should not abandon any patient if we see that he is having severe LV dysfunction like that. So other cases, this is a very interesting case. This is a case from Care Hospital, Banjara Hills, with Dr. Rajiv Menon sir, when I was doing cardiology training in Care Banjara. So 20-year-old male patient, he was a college student from coastal Andhra Pradesh. He was non-diabetic, non-hypertensive, and he came with severe hypotension and low GCS in ER. He was intubated in view of tachypnea, low GCS, hypoxia, and severe hypotension. And when we did his ECG, we found that he was having sinus tachycardia, right bundle branch block with right axis deviation, pointing towards that he must be having right heart pathology. So we did echo. We found that he was having dilated RARV, D-shaped left ventricle, severe TR with severe pulmonary arterial hypertension. Initially, we suspected pulmonary embolism, maybe the reason behind his hypoxia and hypotension and tachycardia and RBB and right axis deviation. But when we saw his old record, we found that he was having dilated RARB with severe PAH since long, and he was extensively evaluated to find out what is the cause of his dilated RARB and severe PH. They did ECG, they did echo, they did transesophageal echo to see if they are missing any atrial septal defect that may be reason of RARV dilatation and PH. HRCT chest to see for any lung disease, CT pulmonary angiogram to see if he has suffered any chronic thromboembolic pulmonary hypertension. Everything was done. After that, he was labeled as case of primary pulmonary arterial hypertension. So, primary pulmonary arterial hypertension, who comes with severe hypotension, cardiogenic shock, is actually a terminal stage in natural history of primary pulmonary arterial hypertension. Same was conveyed to his family, and his family wanted to continue treatment in hospital. So we admitted this patient in ICU, and he was started on IV diuretics, IV dobutamine, IV noradrenaline, and all. By default, any RV dysfunction or LV dysfunction patient comes, we initiate optineuron to that patient, and gradually this patient started to show improvement. His shock resolved, his hemodynamics improved, and we extubated this patient in three days. So now we check his echo, and we found that he was having normal size cardiac chambers, no RARV dilatation, mild tricuspid regurgitation with RVSP of 25 mm of Hg. The all things were reversed. RARV size was normalized, RVSP was coming down. So retrospectively, it was diagnosed that this patient was actually having wet beriberi, which is due to thiamine deficiency. And thiamine in optineuron cured this patient from wet beriberi. So why he was thiamine deficient? So this boy was from coastal Andhra Pradesh, where the staple diet is polished rice with fish. Polished rice is actually deficient in thiamine, and fish contains thymine enzyme, which cleaves the scanty thiamine which is present in the diet. This lead to absolute thiamine deficiency causing wet beriberi, and he was actually having wet beriberi, and he was labeled as primary pulmonary arterial hypertension. So take home message from this case is that don't just blindly trust the diagnosis that is continuing in old OPD cards. Many times nutritional deficiencies can lead to cardiomyopathy. So dilated isolated RARV involvement is also one of the pattern of wet beriberi. Sometimes you will get LV dysfunction, sometimes you can get biventricular dysfunction. Some patient will have isolated RARV involvement. Also, common things should be common. If you are making a rare diagnosis like primary pulmonary hypertension, you are rarely correct. So this is the message from this case. So this was a case of right heart failure. So now third case I want to present. This I recently treated in my clinic. 70-year-old lady. She was non-diabetic, non-hypertensive. She was brought to hospital with complaints of breathlessness, orthopnea, and mild pedal edema. So when clinical examination was done, we found that she was in heart failure. Her pulse was 110 beats per minute, blood pressure was 130 by 70, and her pulse was bounding. Examination reveals bilateral basal cryptations in the lung field. She was very anxious, and ECG revealed sinus tachycardia with ventricular premature complexes. When I did echo, I found that she was having dilated LA, dilated LV, global LV hypokinesia, moderate LV systolic dysfunction with ejection fraction of 40%, moderate MR, moderate TR, and moderate PH. And IVC was dilated and non-collapsing. And in echo, I found that her all velocities were increased across the wall, indicating hyperdynamic circulation. So was her ECG. You can see ECG shows sinus tachycardia, and there are VPCs in the ECGs. So clinical clues were that she was very anxious, and I saw that in span of 2 weeks they have taken 3-4 ECGs, and all ECG shows sinus tachycardia with atrial premature complexes and ventricular premature complexes. So I suspected, is there any thyrotoxicosis? So thyrotoxicosis can lead to persistent tachycardia, and persistent tachycardia can lead to myocardial dysfunction leading to tachycardiomyopathy. So, in thyroid examination and examination of thyroid state, I did tell the patient to outstretch her hands, and I could find that there were fine tremors in her fingers. And in neck examination, I found that she was having thyroid swelling, and in which was confirmed in inspection as well as palpation. So I added this patient on Ciplar LA, which is a non-selective beta blocker. Although she was in heart failure, but strong suspicion of thyrotoxicosis was there, and that needs non-selective beta blockers. That's why I added on Ciplar, and I didn't give her any beta 1 selective or anti-heart failure beta blocker, and I gave her diuretics, Oxra and Vimada, and advised her thyroid profile. And next day she came with thyroid profile report, and you can see that her T3 is 268 where higher limit is 200, T4 is 16 where higher limit is 11, and her thyroid stimulating hormone was less than 0.01. So she was having thyrotoxicosis. So in order to find out what is the reason behind her thyrotoxicosis, is it thyroid inflammation or it is hyperactive thyroid gland, we did technetium 99 labeled thyroid scan, and you can see here there is diffuse increase in uptake on both the lobes of the thyroid gland. So this is the report of the thyroid scintigraphy, that is technetium 99 labeled thyroid scan, which shows that findings are suggestive of diffuse toxic goiter. So actually this lady was having Graves disease. So as it was a Graves disease, started on anti-thyroid medication methimazole, and along with non-selective beta blocker, that is propranolol. And within 4 days, she started to feel better with Ciplar and other supportive medication. After 1 week, she came for follow-up, and her ECG tachycardia was resolved, and it was now sinus rhythm with APC with no atrial premature complexes or VPCs. And I repeated her echo, and I was astonished to see that her LV that was dilated, and due to annular dilatation of the mitral wall, there was mitral regurgitation. LV was dilated, LV was dysfunctional, or changes were starting to reverse. and she had a now normal size LV with ejection fraction of 53%. And previously there was moderate MR, now it was only trivial MR. Previously there was moderate TR with PH, now it was mild TR with no any pressure across the tricuspid wall. So this was a treatment of tachycardiomyopathy secondary to thyrotoxicosis. So in this patient, if you give just blind treatment by just a beta blocker and diuretic and oxra and vimada, and you don't give antithyroid medication or non-selective beta blocker, the problem of patient will not solve. So you should have a generalist approach in every patient that you are treating uh, before going in a deep organ specific approach. So take home message is that etiological diagnosis of cause of LV dysfunction is important. Every patient needs generalist approach first before putting on super specialist organ specific approach. Also, human body is a physiological system. It has multiple organs which are interconnected in one another, and pathology at one organ can affect the physiological function of the other organ, and it can produce a symptom, and that patient can produce with a physiological issue that happening in the other organ. We should find out what is the primary pathology that is causing all these issues. Persistent tachycardia at rate more than 100 beats per minute can lead to fatigue and weakening of cardiac myocyte that can lead to LV dysfunction. So in such patient, treating the tachycardia is important. What is the cause of tachycardia? If it is thyrotoxicosis, you should treat it with the help of medication. If it is due to intrinsic heart tissue issue like any arrhythmia focus, then you should treat with the help of antiarrhythmic medication. If it is refractory to medication, then you should send to electrophysiologist for ablation of the tachycardia focus. That will automatically lead to recovering in LV function. Scenario 4 is 36-year-old lady. She was in one secondary hospital ICU. She was admitted with chest pain and breathlessness. I got a call that one cardiac patient is admitted in MICU. Can you come and have a look? When I went to ICU, I saw that young lady was there and she was anxious. Her pulse was 89 beats per minute. Blood pressure was 100 by 60. Systemic examination was otherwise normal. Her ECG revealed sinus rhythm with no STT changes. When I did the with sinus rhythm with STT changes in the chest leads, when I did echo, I found that she was actually having left ventricular regional wall motion abnormality in the distal LED territories with moderate LV systolic dysfunction. So as I had evidence of ECG changes with in the chest leads and echo confirming LV, RWM in the LED territory, I made a diagnosis of acute coronary syndrome. I gave her stat medication and counseled the patient and attenders that we have to shift to cardiac hospital for further treatment, and plan was to do the coronary angiogram. So this patient was shifted to cardiac hospital and admitted in cardiac ICU. So in social history, I found that she lost her brother 3 days before the heart attack, and after due to heart attack, and after listening about death of his brother, she became very emotional and she started to have chest pain. So she was admitted to secondary hospital. So after stabilization, we did coronary angiogram and we found that she was having normal coronaries. Then why was this LV dysfunction? So retrospectively, we diagnosed that this was actually a case of stress cardiomyopathy, which is also called as Takotsubo cardiomyopathy, broken heart syndrome, apical ballooning syndrome. So we gave her supportive care, and in further follow-up, she regained her LV function, and it improved to good LV systolic function. So what is this Takotsubo cardiomyopathy or stress cardiomyopathy? It is a condition where, due to extreme emotional stress, there is hyperactivation of the adrenal receptor present on the apical areas of the heart, leading to development of LV dysfunction. So LV dysfunction is not always a coronary artery disease. Extreme emotional stress lead to catechomelamine surge and overactivation of catechomelamine receptors on apical segments of the myocardium. This can lead to development of hypokinesia of apical part of the LV, and it is also called as apical ballooning syndrome. So this is treatment is done with IV fluids, beta blockers, AC inhibitor, normal coronary angiogram finding in most of the patient, and recovery to the pre-insult LV function is the diagnostic of Takotsubo cardiomyopathy. So this entity is not so benign. This entity is fatal, and it can lead to sudden death due to cardiac arrhythmia or mechanical issues in cardiac function. So this is also one of the reason of LV dysfunction, one of the reason of development of symptoms of heart failure in otherwise normal patients. Scenario.
Doctor, one small doubt, like before doing coronary angiogram in the 2D echo, could you not be able to find the presence of the Takotsubo findings? Is it a
Yeah,
angiographic
yeah.
diagnosis only?
No, sir. If actually echo findings are no, we can't that much delineate. Very few patient will have typical echo findings of apical ballooning, where apical segments are hypokinetic and basal segments are hypercontractile. But and if you do troponin will also come positive in this patient due to hyperactivation of the apical segment. So once you do angiogram, then only you can confidently tell that we are dealing with Takotsubo cardiomyopathy. Um,
Okay,
so
that's
any new LV dysfunction patient who comes with STT changes, troponin positive, it is a indication for getting the coronary angiogram done, sir. So in follow up, if you follow this patient, they recover their LV function, confirming that we are actually dealing with Takotsubo cardiomyopathy. And in history, we will have a history of extreme emotional stress, like death in the family, like that situation can be there, sir.
okay. Great.
So scenario 5, 27-year-old lady, she developed breathlessness, hypotension, low saturation, post-parturition in one of the secondary hospital, and she was intubated and in view of hypoxia and hypotension. So she developed hypotension post parturition. So she was given IV fluids. After giving IV fluids, she became hypoxic again, and her hypotension was not improving. So they intubated that lady and shifted to surgical ICU. So her pulse was 100 beats per minute, blood pressure was 110 by 70 mm of Hg, and she was started on IV noradrenaline infusion. When I reached there, I found that she was having raised JVP, and there were extensive bilateral cryptations in the lung fields. And her ECG pre labor ECG was having normal, but post parturition ECG showed sinus tachycardia with prolonged QT interval, but there were no significant STT changes in the ECG. So bedside 2D echo revealed that she was having global LV hypokinesia and moderate LV systolic dysfunction, with ejection fraction of 40%, while her all 2D echo that were done in during the pregnancy were having LV function of around 60%. So so a diagnosis of postpartum cardiomyopathy was made. So she was a case of postpartum cardiomyopathy, now in heart failure. So it is also called as peripartum cardiomyopathy, postpartum cardiomyopathy. As the name suggests, it is a condition which is development of new heart failure in absence of any other reason of heart failure in last month of pregnancy or within 5 months post pregnancy. So this is a complex situation where due to multiple issues, the pregnant lady can develop heart failure without any other reason of heart failure. And this can be also prove fatal also. Many ladies they die during parturition due to this undiagnosed problem of postpartum cardiomyopathy. So this lady was treated with IV diuretics, and after diuretic I started slowly her on beta blocker, AC and MRA. And breastfeeding was not advised due to use of AC inhibitor, which are nephrotoxic to the, and they are excreted in the breast milk. So there was no any obvious cause of heart failure, but it is due to different pathological issues in peripartum period. So if patient is hemodynamically stable in the pregnancy and you detect that patient had developed LV dysfunction, so you can continue with medical management followed by delivery by neuroaxial anesthesia or as a natural course. If the patient is hemodynamically unstable, then you should do the delivery to reverse the cardiac issues, because if you will not do delivery, then patient the mother will get deteriorated cardiologically and she will have fatal outcome. So what about further pregnancies in these patients? Patient with presenting left ventricular ejection fraction less than 20% should avoid or no recovery of LV function, that is LV ejection fraction persistently less than 50%, should avoid further pregnancies. So sterilization procedure should be done in this kind of ladies to avoid further accidental conception. So those patients who recover their LV function, who are more than they recover LV function more than 50%, they should be counseled that this disease can again recur in next pregnancies, and they should be counseled to avoid pregnancies in further. But those who have LV function less than 25% and who have not recovered their LV function, they should be told not to have another further pregnancies. So this was the case that I treated with postpartum cardiomyopathy. So scenario 6 is a 67-year-old lady. She is still under follow-up. She was diabetic hypertensive and she suffered acute coronary syndrome in 2013. So she was
One
brought to.
quick question on the earlier case, doctor.
Yes,
Like,
yes, sir,
what
yes,
is
sir.
your experience like? Peripartum cardiopathy is a recurring problem with every future pregnancies, or
Those
uh,
patient, it can recur also, sir, or it can not recur. We are not we can't tell in which patient it can recur. But
mm,
those patients who have persistent LV dysfunction, they should be advised not to get conceived. But those patients who have recovered their LV function more than 50%, they can conceive, but cautiously they should be told that it is better you should not get conceived, because we don't know if it again recurs in next pregnancy or what.
another question is the peripartum cardiomyopathy is a declaration that the signs are identified only during the final trimester or even in middle trimester, or earlier we will be knowing that which subset of patients are going to enter into a peripartum cardiomyopathy.
Those patients who have pregnancy induced hypertension, or have preeclampsia and placenta previa, these patients have tendency to develop postpartum cardiomyopathy. And we don't have any other reason of LV dysfunction, like there is no mitral valve pathology or there is no coronary artery disease, and pre-pregnancy LV function was perfectly normal. These patients usually are develop postpartum cardiomyopathy or peripartum cardiomyopathy. And it is commonly seen in Asian females, and uh, things like selenium deficiency and poor socioeconomic strata patients are more prone to develop peripartum cardiomyopathy, if you see the demographic data regarding peripartum cardiomyopathy.
Good. Yeah.
So scenario 6, 67-year-old lady, she was diabetic hypertensive. She suffered acute coronary syndrome and she was brought to hospital in ST elevation MI as a ST elevation MI, and she underwent primary angioplasty to LAD, and later right coronary artery was also angioplasty was done, and she was having mild LV dysfunction when she was discharged in 2013. After that she lost follow-up. In 2018, she again came. Now she was in congestive cardiac failure, and ECG done, it showed atrial fibrillation with fast ventricular rate, while echo showed global LV hypokinesia with severe LV systolic dysfunction. And when I reviewed her file, I found that she is actually now CKD patient, and she was on maintenance hemodialysis thrice a week in nearby hospital, and her sugars were also uncontrolled. It was around 500 milligram per deciliter random blood sugar. So this patient needed treatment at multiple levels. Her creatinine was 11, so very low GFR. So diuretics were not going to work in this lady. High sugars were causing asthenia due to loss of sugar in urine and no nutrition to the muscles. Her uremia was also causing asthenia. Cardiac dysfunction due to congestive cardiac failure was also causing breathlessness, shortness of breath, and weakness. So I slowly started this lady on anti-heart failure medication, Ernie and MRA. So CKD patient who are pre-dialysis, your hands are tied. You can't give Vimada and aldactone. But once if the patient is on dialysis, then you can freely give angiotensin receptor neprilysin inhibitor and aldactone. And this patient, these patients are on hemodialysis, so if there is any hyperkalemia is developing, the hemodialysis will take care of it, and you are free to give this medication and extract the cardiac benefits without without worrying much about the kidney issues once the patient is on hemodialysis. So I put this lady on Ernie and MRA, and I controlled her sugar with the help of Lantus and human actrapid insulin thrice a day, and beta blocker I added her. And those patients who are on hemodialysis, Cardivas is the beta blocker of drug of choice in this patient, because Cardivas is non-dialyzable beta blocker. So even if the patient undergoes dialysis, it will not get removed from the body, and you will get persistent benefit of cardioselective beta anti-heart failure beta blocker in this patient. So she was having anemia. That anemia was due to CKD as well as heart failure. So I gave her ferrium and B12 and folic acid and Miaxon injection, Miaxon with the help of injection Miaxon. Initiated this lady on erythropoietin, and her HB started to improve. The target HB in CKD patient is around 10. So once her HB improved, her ERNI and MRA and beta blocker started to take action. She started to improve. I slowly titrated her anti-heart failure medication. So after correcting her sugar, anemia, CCF, CKD, she started to feel better, and her symptoms resolved. And she is in follow-up since 2018. Still, she comes to OPD. So at that time in 2018, she was told by that looking at her LV function and cachexia due to multiple issues, family was told that she won't survive even for 6 months. But again, with the help of all medication and all, it was all proven wrong. Severe LV dysfunction is a not death sentence to the patient. Once you start the patient on correct therapy and you treat the other problems with the patient is having, not just cardiac problem, they do well and they do good. So severe LV dysfunction is not you should not think that it is a death sentence. You can see her when she came to me at the when the echo was done in August 2021. It showed that she was having dilated all cardiac chamber, global LV hypokinesia, and severe TR with mild PH. RV dysfunction was there, and moderate LV systolic dysfunction with ejection fraction of 38% was there. And after starting her on all medication, within around in 8 months, her LV function improved, and she was now having global LV hypokinesia with mild LV systolic dysfunction. It was around ejection 49%. So heart failure medication work. If you do proper titration of heart failure medication, they do wonders to the patient. They not only give symptomatic benefit, they will give mortality benefit also. So now I want.
Doctor,
Yes,
one quick,
yes sir.
uh,
Yes sir. Yes sir.
uh,
Yes sir.
can there be a global LV hypokinesia with only a mild LV systolic dysfunction? Is it
Yes,
possible?
yes, sir. Yes, sir. Yes, sir. Mild global LV hypokinesia with mild LV dysfunction comes, sir. It is normally there in many cases. Mild global LV hypokinesia with mild LV dysfunction, sir.
But here we have global LV hypokinesia, that is, all chambers are not moving well, right? Acha, if they are
Yes,
mildly hypokinetic globally,
yes, 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 sir. Yes, sir. Yes, sir. Yes. Mild, mild is missing there, sir. It is my report only, sir. Mild, I have missed to write. Many times we get this scenario, sir. Well, mild global LV hypokinesia with mild LV dysfunction can be there.
because you wrote global, I was worried,
Yes.
right?
Yes,
Yes,
sir.
okay.
Yes.
All
Yes.
right.
Yes. Yes.
Point clear. Yeah.
Yes, sir. So there are now we are having five pillars in heart failure management: beta blockers, gliflozins, ARNI, AC, ARB, MRA, and vericiguat. So heart failure management is in what happens in heart failure. There is activation of renin angiotensin aldosterone system, and there is activation of sympathetic nervous system. So we have to block this overactivated sympathetic nervous system and overactivated RAS. To block overactivated sympathetic nervous system, we have beta blockers, and the tested beta blockers in heart failure is metoprolol succinate, bisoprolol, and carvedilol. Important here is that metoprolol succinate will give anti-heart failure benefit. Metoprolol tartrate, that is beta lock, is not having any anti-heart failure benefit. So you should use metoprolol succinate, bisoprolol, or carvedilol. So there are different characteristic to these beta blockers. So if you are worried about if your patient is having high blood pressure, then carvedilol or metoprolol succinate is okay, because carvedilol has vasodilator properties also. So if your patient is having borderline blood pressure and you are not sure if you give beta blocker, patient will develop hypotension, then bisoprolol is the beta blocker that you can use, because it is very highly cardioselective and it doesn't has any much effect on blood pressure. So patient who come to you with BP like 100 by 60, you can give bisoprolol in them when you want to give benefits of anti-heart failure to them. RAS blockers are angiotensin receptor neprilysin inhibitor, AC inhibitors, and ARB. So many times we get patient and we put on Vimada, and Vimada is costly and this medication is costly. But I personally saw that even if you put patient on valsartan or you patient on enalapril, they do wonders. So if you are unable to put patient on Vimada, don't miss to put patient on either valsartan or enalapril. They do wonders with that. Then RAS blocking we can do with the help of mineralocorticoid receptor antagonists, aldactone and eplerenone we have. They do also do wonders. Also in ARNI, that is angiotensin receptor neprilysin inhibitor, heart is not just a pumping organ, it is an endocrine organ also. Why I am telling that? Because when the heart LV and RA and LA and RV they get stretched, they release some natriuretic peptides. This is called as natriuretic peptide system, ANP, BNP, CNP. So these ANP, BNP, CNP, these are the natriuretic peptide. These will cause natriuresis and diuresis in heart failure patient. So the scientists tried to develop one chemical which will prevent the metabolism of this natriuretic peptide. The metabolism is done by neprilysin, and neprilysin inhibitor is the sacubitril. So they combine the ARB, that is proven in heart failure, that is valsartan, with neprilysin inhibitor, that is sacubitril, and form ARNI. So ARNI, if you give, you are not only blocking renin angiotensin system, but you are augmenting the natriuretic peptide system. By neprilysin inhibitor, you are not allowing ANP, BNP, and CNP in body to get metabolized. And with increased level of ANP and BNP in body, you will get benefits of natriuresis and diuresis in this patient, and the reverse remodeling of the heart will uh, increase along with beta blocker and RAS. So now there is paradigm shift in treatment of heart failure. Previously, we used to block only sympathetic nervous system and renin angiotensin aldosterone system. Now, along with the blockade, we are augmenting the natriuretic peptide system. So this is a paradigm shift. Again, we have one more weapon in our fight against heart failure, that is vericiguat. Vericiguat is a drug which is given in those heart failure patient, unfortunate patient, who despite on being all medical therapy, and if any device therapy is required, they are on that device therapy, but they are getting admitted recurrently with heart failure, that is worsening heart failure. In this worsening heart failure, vericiguat is beneficial. It will increase the level of cyclic GMP in the cardiac muscle, and it will help the patient. So these are the five pillars in heart failure management. Along with that, I think that now the evidence is coming that treating iron deficiency is also important in patient with heart failure. So iron, if the you after putting a patient on this medication, once LV function is improved, once your edema has gone, then you should do the coronary angiogram to see if there is ischemia happening in the patient, or if you have direct evidence of ischemia, you could get coronary angiogram and you should treat the coronary artery disease with intervention. So that is also important in while treating patient with heart failure. Many times they have ischemic cardiomyopathy, and once you treat the ischemia to the myocardial cell, the LV function dramatically improves. We have many patients who have significant coronary artery disease leading to ischemic cardiomyopathy, and once you do stenting, or once you do coronary artery bypass graft, their LV function suddenly improves and they do well, and they don't require anti heart failure medication also in rest of the life. That is important. So other thing is that treating iron deficiency is important. So iron deficiency is a new concept in treatment of heart failure. So heart iron, normal hemoglobin is not a guarantee that patient is not in having iron deficiency. Body tries to maintain hemoglobin at all cost. So whatever iron is present in body, it uses to maintain the hemoglobin. Iron is required other areas also, like iron is required for myoglobin to function. Iron is required in the mitochondria for the cytochrome enzymes to function. So if the patient is developing iron deficiency, body will extract iron from myoglobin, extract iron from cytochrome, and it will try to maintain hemoglobin. So even if hemoglobin is normal, patient can have iron deficiency. So how to detect if the patient is having iron deficiency? There are different criteria developed to find out iron deficiency. So heart failure and CKD and inflammatory bowel disease, these are the um, chronic inflammatory conditions. In this patient, the usual criteria that we apply to the normal patient without inflammation, we can't apply here, because in this patient ferritin is falsely elevated because it is a chronic inflammation, and ferritin is an acute phase reactant. So in this patient, if you do ferritin, it will come elevated falsely, but it will not tell us if even if the patient is iron sufficient or not. So in heart failure, if ferritin is less than 100, then we tell that patient is iron deficient. Or if the ferritin in between 100 to 299, but transferrin saturation is less than 20%, then it is heart iron deficiency. And iron deficiency is irrespective of hemoglobin level. Even if hemoglobin is 11, patient can be iron deficient. And personally, I have seen that once you treat iron deficiency in heart failure patient, their LV function, their blood pressure improves, and their asthenia improves, because iron is required for function of myocardial cell. So once you give iron to that patient, the myocardial cell contractility and ability to contract increases, and they generate more blood pressure. And once they start generating more blood pressure, you can give anti heart failure medication to them, so that you can extract the benefits from the anti heart failure medication effectively. So treating iron deficiency is one of the important intervention that you can do while treating the heart failure patient. Also, there is one more concept, paradoxical response of anti heart failure medication. Many times we have patient with heart failure who come with severe LV dysfunction with ejection fraction 30%, and their BP is very borderline, like 100 by 60, like that, and we are not sure how we can add beta blocker, how we can add a Vimada, how we can add a valsartan, how we can give diuretic to them. But you have to start this patient on minimum dose of anti heart failure medication. You have to treat iron deficiency, and once these anti heart failure medications start acting, slowly the contractility of the heart improves, and the blood pressure of the patient improves, despite you are giving beta blocker, despite you are giving ARNI RAS blocker, despite you are giving diuretic. Once their cardiac function improves, their BP improves. This is a paradoxical response when while you are treating heart failure patient, despite you are treating with BP lowering medication, on long run their BP will improve due to decrease in LV size and increase contractility of the LV. So, along with treating iron deficiency and anti-heart failure medication, you should give medication that coenzyme Q and mitochondrial enhancers. These are the medication, although they are not that much proved in any clinical trial, but in my clinical practice, I have seen that once you give these supportive enzymes, the patient tell you that, sir, you have added this medication, I am having excellent benefit with this medication. Along with, so while treating heart failure, you should not miss other comorbidities that the patient is having. Like if patient is anemic, you should treat anemia, maybe due to iron deficiency, maybe due to folic acid or B12 deficiency. If having CKD, you should optimize the CKD treatment. If thyroid issues are there, like hypo or hyperthyroidism, you should treat it. Dyslipidemia, you should treat it. Nutritional deficiency, you should treat it. So you should treat patient as a whole, not just organ specific. And once you start to treat different pathologies in different organ system, have positive benefit in one another organ, and patient will get overall improvement in his symptoms. That is the motto behind internal medicine. Internal medicine, we are unable to 100% cure many diseases, but we can optimize the physiology of patient so that patient symptoms can be relieved and patient is able to do his or her daily day-to-day activities. And that is what cure for the patient. Although it is medically not a cure, but it is socially cure for the patient. So with note,
In fact, that's a very important point that you mentioned. That a lot of times when the hemoglobin is around 11, also patient can have iron deficiency. So generally, I depend a lot on the distribution width. That is the red cell distribution width, which is an indicator of poikilocytosis and anisocytosis. That's an important marker. The moment RDW increase, that means definitely patient is having iron deficiency. Unlike
yes,
in other causes of microcytic anemias like thalassemia, where RDW is normal, but in the case of the iron deficiency, it is increased. And today we are all depending a lot on the distribution widths. Recently,
mm,
they found monocyte distribution width, MDW. MDW
okay,
is a very important indicator of early sepsis. Even before procalcitonin and all these things kick up, the monocyte distribution width is going to revolutionize the CVP report in the times ahead. So it's a very, even I share the same experience as you, doctor, that iron deficiency correction is the key factor which is missed by the time we finish DM cardiology. Probably we forget about levogen, we forget about iron, folic acid, and all this. And 24x7 we are busy with putting angiogram, doing stunts, and managing the interventricular septum, etc., with interventions. So but these small things, the god lies, भगवान छोटे रहता है. So that is what
yeah,
you have once more doubly proven to be a very strong physician in spite of subspecializing the cardiology. So wonderful, doctor. And earlier also, when you mentioned about the case of the cardiomyopathy, I mean, sorry, and thyrotoxicosis associated cardiomyopathy. Here I want to quickly tell there are two kinds of thyrotoxicosis, primary and secondary. So there are certain features with which we differentiate. Most of the times, what we see clinically is the primary thyrotoxicosis in younger population. But whenever thyrotoxicosis is happening between 25 to 40, that is the time where we need to think about secondary thyrotoxicosis. Secondary thyrotoxicosis predominantly has got a cardiovascular involvement, whereas the primary thyrotoxicosis predominantly has a CNS involvement, is what you need to remember, which is a very important differentiator. Also, the eye signs are not found, as you can see in the case presented by Dr. Syed, that eye signs are not predominant. So if the eye signs are predominant, there is more likely to be primary thyrotoxicosis, whereas they are rarely found where there is a cardiac involvement. Similarly, if you look at the surface consistency of the thyroid, also there are a lot of clues. Nodular thyroid, firm or hard, is a more of a feature of secondary thyrotoxicosis, whereas when the thyroid is soft or firm and smooth, it is more likely to be primary. And also, we need to know that the duration of the features. Always primary thyrotoxicosis, if you look, the duration is very short, presenting features. But in the secondary, there is a long duration of a swelling. For a long time, mere paas ye swelling hai, Dr. Saab, is what the description. And the symptoms duration is short. Signs duration is long, symptoms duration is short. That is secondary, where cardiovascular involvement, whereas signs and symptoms occur together is the feature, like the neurological symptoms like tremor, is more a feature of primary thyrotoxicosis. Clinically, is what we need to always remember and practice day in and day out. So thank you so much, Dr. Syed. I
Thanks a
was
lot, sir.
thinking, how do we manage this Friday? But you took your time and pushed me to do, because when we start something, we need to do it till the end. So in Sanskrit, they say, Arambhincharu Nicha Manaval. Those who are Nicha don't start only. Much in Nietzsche are the people who start and give up. But those people who continue the tradition are the ones who are remembered. Last week also we learned a lot on the DVT. This week we are completely enlightened about the basic principles of clinical management of CHS, which is one which is not taught among many things not taught in the medical college. So thank you so much and look forward to see you
Thanks a
next
lot, sir.
week.
Thanks a lot, sir. Thanks a lot for giving me opportunity. Thanks a lot, sir.